Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around our country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to Bright Spots in Healthcare, I encourage you to do so. We have so many great guests, like the one I'm about to introduce to you right now, who are providing all kinds of great insights and bright spots. I would say the last 2 years of episodes have evergreen kind of length and stay to them. Go to Bright Spots in Healthcare, type it in wherever you listen to podcasts, or just simply go to brightspotsinhealthcare.com and you could find your links there. But wherever you listen to podcasts, you will find us. And if you like the show, I encourage you to rate us as well. Okay, our topic today is behavioral health and whole person care, and features an incredible guest. Really super excited to finally get him on the show. Kody Kinsley, the Secretary of the North Carolina Department of Health and Human Services in the state of North Carolina. They are doing a lot of cool things that we're going to talk about in a moment. Kody serves as their secretary, overseeing the department with over 18,000 staff and a $38 billion budget. He has experience centered on health policy and operations. Kinsley worked on digital healthcare transformation, national education and labor policies, and served as the COO and CFO of the U.S. Treasury. Incidentally, Kody, you're the second COO of the U.S. Treasury that I happen to know, which is a strange stat. Secretary Kinsley's 3 priorities of the department include investing in behavioral health and resilience, our topic for today, improving child and family well-being, tied to our discussion today for sure, and building a strong and inclusive workforce. Under his leadership, North Carolina expanded Medicaid and received the largest investment to bolster the mental health system in over a decade. He grew up in Wilmington, earning a bachelor's degree from Brevard College and his master's in public policy on the other side of the country from the University of California at Berkeley, but now joining the ACC, so they're like home now to you.
Go Bears.
Go Bears. So thanks for being here, Kody. I really appreciate it. Secretary Kinsley will be formal if you want. I want to sort of set the stage for you, because everyone knows in the area of mental health, we have a disproportionate ratio of low supply and high demand. And that's prevalent, obviously, throughout the entire country, not just in the state of North Carolina. However, I know from my experience that even though there is a shortage of supply, what's worse is we're not very good at connecting demand and supply. So there's still some supply out there going unused, despite sort of the long lines around the proverbial block to get in to see a mental health therapist or even a psychiatrist. So I want to start with, how is the state thinking about maximizing capacity for individuals in need?
Well, Eric, it's great to be here. And I love the way you think. I love this question because, there has been a mismatch in supply and demand for behavioral health for a really long time. And you can't, I think, start any conversation about behavioral health not to first touch on, to kind of use this economics language, the information asymmetry driven by stigma, right? There's been a lot of folks who have been unwilling to come forward, even because they have felt that behavioral health issues were a moral failing. And I think there's some good news, which is, on the other side of COVID, people experienced issues around behavioral health in a way that they hadn't before, and they're coming forward. So that's good. Check one. We're starting to see folks. But to your point, there's a mismatch in supply and demand. So one of the things we've seen in North Carolina is that, like many other states, we have been on this journey of building more and more beds over the last several decades. And on any given night, still, we'll have about 350 people sitting in EDs across the state looking for a place to go. But here's what's interesting. We instituted a new data system to, in real time, start to track both the ED bed holds and how many available beds were across the state. For the first time ever, after we put this bed system in place, I can tell you that on most given nights, and I usually like to play this as a Jeopardy game and have people guess, but I won't make you guess. On most given nights where we have 350 people sitting in an ED with nowhere to go, we'll also have at the same moment about 120 empty staffed beds in the state. And it's just a total mismatch in the system. Now, part of putting the system in place is to help unlock that potential so people know where to go. But it also helps us as policymakers understand why. Now, part of it's a geography problem. It's not in the right place. Part of it's an acuity problem. And so the right shape and size of bed are not available for the unique, right? Because not all behavioral health beds are the same thing. And then we've been able to kind of tailor systems around or I should say kind of benefit responses around trying to fill that need to get people into those beds and make sure that they're fit for purpose to unlock that existing potential that was already there. Because look, up until this point, the conversation in the state has only been, we got to build more beds because that felt like the proximate problem. But this data system we put in place in the last year has really opened our view that that's not our problem. Our problem is we have to get people into the beds that we already have and make that possible.
So tell me a little bit more about how that's being accomplished. So I like how you define the problem, and you're alluding to that you have a solution. What is that solution? Like how did you model that out? Because my guess is that's something that could be a potential bright spot, a clonable bright spot, if you will.
Well, and it was a learning for us that we built on from our COVID response. So like many other states, we put data systems in place to have bed data shared with us daily about COVID utilization in our hospitals. At some point, we thought, well, why don't we also see what their psych bed use is, and why don't we also understand what their psych holds are? Now, obviously, there's a lot of different organizations you could work with to do this. You could do it through HIEs and a variety. We partnered with a company called Bamboo and their Open Beds platform to build on this and make this possible. So now we're getting from each of our hospitals daily to a central location insight into how many people are ED bed holding. We've got have to do all the common data definition, that sort of stuff, and where the open beds are. We've now also started to open up that data to the actual entities, because if you were to talk to any hospital, they would tell you they've got a team of social workers that are flipping through spreadsheets, calling places to find a bed, and they put an application in and it waits, and there's a whole other set of problems that flow from there. But now we've jump started through that process, and we give people at a snapshot, real time, where the open beds are. So they know where to call, they know what to go after, they know what applications to put on. We're building on this system because we want to turn it into a centralized application repository. So that way, as opposed to even having just this, it's a huge step forward just to be able to have one place to start with on who to call and what to go after. But now to be able to say, poop, here's my, for those that aren't watching, pressing the button, and you can put your application in and it shoots out. The reason why, that's great for my hospitals that are trying to do discharge planning. It's also great for me because I get to see where things aren't working and how to fix it.
So I want to know how integrated this is. So the system does a provider system have to subscribe to this platform? What are we calling it, first of all?
We've been calling it our crisis bed system.
So your crisis bed system, the CBS. Or in healthcare.
I'm trying to get away from acronyms. We're working on it. I know that's hard for government, but step one was, people were doing data entry. That was unsustainable. What we've done now is we have piped it into the EHRs, so that way it's passive and seamless. And some of our health systems, are giving us data daily. But we've got a couple now that are giving us real time straight from the EHR. Part of that was, we had to build the trust with them to share that amount of transparency. But again, I think we built on the backbone of our partnerships during COVID to use this data appropriately.
And does it integrate with does it integrate with the big systems like the Epics and the Alteras and everywhere else? And then
it's like 78+% of North Carolina is on Epic. And so that's mostly what they're integrated with, but we will integrate with any EHR.
That's fantastic. And can we make the appointment? So I'm managing a psych hold right now in the ED. I go into the system. I find the right bed for that particular individual. Am I able to make, am I able to automatically fill the bed? Like, how does that appointment work?
That's our vision space. Right now we are finding the bed and seeing it, and then you have to kind of step into a separate process to get into the bed. We want to take it all the way. And we actually have a RFP out on the street right now to build some of that capability. And so for anybody listening who wants to change the world, I think this is our opportunity to work on it together.
That's great. Where would they go for that, by the way?
ncdhhs.gov.
Perfect. So any early results so far? Is there any direct, maybe it's too early to show it, finite results, but is there anything directionally? I don't know.
Well, the first thing I'll say, and this is a more of a policy outcome for my fellow policy folks listening, is that it allowed us to define the problem in a different way. And I was able to shift our legislature's focus from just throwing more money away into building beds that are going to come online in 5 years and put that money into what it needs to go in. We increased our Medicaid rates we doubled our inpatient psych bed rate. We increased our Medicaid rates. We spent about $200 million in state funding to increase across Medicaid. That could have never happened had we not had this sort of corporate view over what was going on to define the problem. But yes, people are able to find these beds more quickly. We've had a significant double-digit % reduction in wait times in certain geographies. There's some variety based off where people are, and so there is really good turnaround in just centralizing the information. But for me, it's not done until it can go straight through and you can do a centralized application.
So just high-level summary of the results as you see it, and just fill in the blanks if I missed anything. First and foremost, it allowed you as an organization, right, to define the problem in a different way, and that colored all the different policy and even business decisions that the state made. It doubled your inpatient psych rate. It doubled digit reduction in wait times as well. You also said it doubled our Medicaid rate. What do you mean by that?
Oh yeah, for the inpatient psych rate that we pay for Medicaid, we were able to get, using this information, we were able to get the investment necessary from our legislature to double that rate, which of course is also helping get people in beds, because a lot of the reasons why those beds were sitting empty was not because they weren't being found. Eventually, they're getting found faster, but now they're actually being paid for in a way that will sustain the services necessary for these high acuity patients.
Got it. Now, as you're solving this bed problem and squeezing out all the value that the state has in their existing beds, there's still obviously significant capacity challenges. And one of my soapboxes, not just for mental health, but in all areas of healthcare, as we evolve into the next generation here, is we need to militarize our population of, we'll call it consumers, some may call them patients, to help each other in taking better care of ourselves and in even helping treat each other and support each other around subacute situations. And so I'm curious how you are leveraging the citizens of North Carolina to help each other in that regard. And if you could tell me a little bit about that.
I love this frame and the way that you approached it. Well, let's just tack on to where we were. So people have been so focused on the problem right in front of them that they're missing that part of what drives that problem is that there's no upstream intervention. And we have a workforce problem in this country for behavioral health. When you've got something that has been ignored as long as it has been ignored, and unfunded as long as it has been unfunded, then you don't have enough mid-levels and all the way up to psychiatrists of behavioral health professionals. So this huge untapped opportunity is, let's engage the people that are actually in recovery with behavioral health challenges to be a part of the solution. North Carolina has established a peer certification program where, as folks are, struggling with serious mental illness or even addiction, and they're moving into their path of recovery, they can get certified to become a certified peer support specialist and counselor. We not only is that a great sense of stabilizing their recovery, it's an economic means for them. But one of the things that we launched very recently that I'm really excited about is a peer warm line. This is a phone line that is available, and it's also text, chat, all those things. Phone is the legacy frame, but all the communication channels that is staffed by peers, so that if you are struggling with addiction or struggling with mental illness and you need to talk to someone, I like to say that if you're in a tough spot, talking to someone who's been on that path before is probably a good person to talk to. You can pick up the phone and they're available 24/7. This is in addition to our 988 crisis line. The federal government established the 3-digit dial 988. North Carolina launched our line a couple of years ago. We have one of the lowest wait times in the country, a very, very high answer rate. We've had a very, successful launch of that. But now we want people to be able to also call the peer warm line, because, just because you're not in crisis doesn't mean you don't need help. And maybe you're still in between therapy visits or in between seeing your psychiatrist. You need someone just to help you along. This peer warm line's available to folks. And it's about building more upstream infrastructure for us that prevents people from ever ending up in the ED in the first place. Because that's the other side of the puzzle in trying to reduce those bed wait times. I just wanting people wanting them in the first place. It's a lot easier to keep people stable than it is to, push them back to stability on the other side of a crisis.
Well, there's some things I want to unpack. I want to double click on the crisis system or crisis line in a moment, because you said some things I want to make sure everyone knows how you got there. But before we go to the 988 line, let's stay with the peer warm line. So any results here? Like first of all, how many peers have been trained through this certification program? How long is that program? Does it take to get through it? How is it designed? And then maybe how big of your army do you have right now of peers?
So we've actually got over 3,000 peers certified in North Carolina. And this is something I'll acknowledge. We put our peer certification process in place a couple of years ago. We use some national standards. We have, we allow for 5 different standards, and then we let whatever company that wants to do it. In some instances, we pay for the certification. In some instances, the treatment provider will pay for it as a kind of a way to support the person they're working with in their recovery to kind of do the next thing that's going to help them. But our learning, and maybe this is a bit of a bright spot, our learning in the last year has been that people were doing the certification and then just stopping. They weren't getting a job with an insurance plan or with a provider to provide peer services. They weren't getting connected. And so we really started in the last year rebuilding that connective tissue to try to then help people keep on the job prospect. One of the things that we did to help facilitate that is we established a Medicaid service definition that pays for peer support specialists. We used to pay for this solely out of state dollars as part of reimbursement, but now it is an insurance Medicaid reimbursable service. And so providers started hiring peers because, it's a lower cost to them to hire a peer and they get reimbursement for it. So it's a nice way to help manage issues. Hospitals started hiring peers because when people were showing up in, they just had a naloxone reversal from an opioid overdose. Who better to say, Eric, you're at a really tough moment in your life. You're in here. We just gave you some naloxone. I was where you are a year ago. Let me help you figure out what's next to try to go into recovery. And so hospitals have been hiring peers just to have them sit there. They call these peer living rooms. So the people are there and available. We've been investing in scaling more peer living rooms across the state. And this peer warm line is our latest intervention in that puzzle piece. So I'm trying to get this workforce out there in a variety of different venues to help get people more connected to care, especially our SMI, our seriously mentally ill population that needs such intensity of service and care to stay out of crisis.
And these peer living rooms are physical locations in hospitals or other locations?
Both. So some are physical locations in hospitals, but some of them are something. The model is called a peer clubhouse. This has been around for a while. Fountain up in New York really leads the way. Fountain House in the way on this, and we've got a few in the state. But essentially, think about it as like a day center for people with serious mental illness, where peers are staffing it and they're help supporting people. There's not psychiatry and therapy happening there, but they're shown to be really low cost interventions that keep people out of crisis and give people meaningful day activities and things that they need to do to be supported in their community.
And you said Fountain Health in upstate New York?
Fountain House in New York, they really have led the way on peer interventions.
I love this. And what's the plan for this program moving forward? Is it at the level or size that you want it to be? Is it going to grow? Are you going to move it over to other chronic illnesses?
So actually one of the additional things that I want to add on specific to mental health is really something called family peers. So this is a particular challenge area, I think, in our country, which is that we're having a lot of youth mental health issues. Children are ending up in psychiatric care. That can sometimes be a very brutal process. And the entire healthcare system is designed around responding to the needs of that child and never thinking about the needs of the family. And so there is a growing cadre of family members who find real meaning and purpose in becoming certified family peers to try to help be that coach and that guide and that sounding board for that family member that says, look, I was where you are. This is how I navigated the system. This is what we do. They have an expertise in figuring out their path through that. And, I'm trying to break cycles where mental health challenges are really festering in families. And what is happening is that we take kids with these really intensive psychiatric needs, we provide treatment, and then we put them right back in their family without any care and support for the family. So there's a whole lot of other things we're trying to do around meaningful family interventions and different types of program design that's supporting those families. But one big piece of it is right out of the gate, I want family members to have someone to call when their child goes into a crisis situation that can both help manage. Once the child's crisis has been stabilized, help them know here's what's next and you're not alone.
And like the peer certification program where you're using probably qualified third parties to run those programs, I'm assuming the certified family peer program, same thing.
Absolutely.
Yeah, I love this. One of the bright spots, one of my favorite bright spots that exists that gets largely ignored, that when you get me on my soapbox, and you have, so too late, is that we ignore in healthcare is the power of the peer program and the peer mentor program in Alcoholics Anonymous. It's a tried and true generational successful program that is the basis of it. I know there's some components to it and some religious basis and all that, but even if you're not religious, that peer support, that peer mentor program is the foundation of it. And I've always wondered why we haven't figured out how to apply it to mental health, how to apply it to type 2 diabetes, how to apply it to hypertension and other cardiometabolic diseases in a way that's more effective than we're doing now. So you definitely struck a chord. I'm super excited that you're doing all of that.
Well, Eric, to grab something far afield, you'll be excited to know that we just launched a new effort to pay for group prenatal care. So we are trying to tackle maternal mortality disparities in North Carolina, and there's a great evidence base behind exactly what you're talking about. I need to put a lot of pregnant Black mothers in a room together to build community and to support each other through the process. So that way they can, hey, my physician said X to me. I don't know if that feels right. Can I gut check with you? And that relationship, the evidence base is clear. The relationship that you build among those pregnant mothers in that moment is really good at helping close that mortality gap. So we're really excited about peer models and those sort of group approaches in a lot of places.
Oh, I super love that. Is there a place that if I or any of our listeners wanted to go learn more about your peer support models, that we could go? Is it NCDHHS or is
Yeah,
it?
that's our website's great, ncdhhs.gov. But I'll just, for the sake of putting it out there, tell everyone 1-855-PEERS-NC is our phone line, and it's available 24/7. So if you are listening in North Carolina or heck nearby, and you want to talk to someone with lived experience as you're struggling with mental health or addiction issues, give us a call.
Love that. Say that number one more time.
1-855-PEERS-NC.
1-855 PEERS NC.
NC, North Carolina.
Yeah. Or if I missed a number there, great job. I love that. All right. Before we totally leave, I'm not forgetting about the 988 crisis line. You said one of the lowest wait times in the country. How did you get there? How's that crisis program so successful?
Well, so we have an amazing team that is leading this crisis call center in North Carolina. But one of the things that we did during COVID, we knew 988 was coming, and states across the country were given additional funding during COVID to do a lot of things, of course. But one of those things was setting up a kind of post-crisis response line. This is something that we're familiar with in North Carolina because every time we get hit with a hurricane, SAMHSA comes in and gives us some money to do kind of community counseling programs and set up a line. And we'd always set up a separate line, blah, 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 blah. So we had the idea during COVID, let's not set up a separate thing. Let's just invest in our call line that we have already for crisis and just build out the capability so that they're both doing mental health crisis and just de-escalation broadly and just frankly someone to listen to. And so before the 988 number went officially live with the FCC, we had been using a lot of our dollars that were intended for this kind of collateral purpose, braiding them into the existing program and building the skill. So when 988 launched, we had essentially been running that speed for 2 years already. And so to me, I think the bright spot here is, and this is I think one of my vantage points, having worked at the federal level for as long as I did before coming home to North Carolina, there's a lot of different programs running out of the federal government that frankly all feel the same. And, if we can figure out ways to braid those together and create kind of a seamless experience at the state level, then more power to it. You get a leveraging effect with those dollars.
So what I'm hearing, just to summarize a little bit of this conversation, and we'll put the peer support program over to the side for a second, even though that's near and dear to my heart. Your program for centralized beds, CBS, you don't want me to call it that. That program came out of COVID and a system you built for that crisis. And now your 988 line, you got ahead of the curve because you already had it in place for all the crises that you have when a hurricane hits, and you repurposed that and enhanced it. And boom, now you got 2 ongoing permanent programs that help make up the infrastructure for your entire Medicaid system that are working to improving healthcare for everyone.
Absolutely. I call these price opportunities.
It's great.
And why build it temporary? Build it for the future.
I love it. So, God, a couple more questions. I know we're going to run kind of short on time in a moment here. As you're thinking about, so you have all these great programs in place. How are you bringing it all together as a state, as you're thinking about whole person care, as all your private commercial partners in your state are thinking about whole person care, and the design of benefits that have to go into supporting that and everything in between as a big health payer, right? What is the state doing around benefits design to improve overall care for your Medicaid members?
Yeah. So starting with the kind of fundamental problem here is that every dollar you spend on Medicaid services, and frankly, health insurance broadly, right, is too late to actually really improve the health of the people that you're serving. What I mean by that is we know that 80% of what drives health is not what happens in the doctor's office. And so North Carolina's strategy has been, how do we get more upstream? I think two key ways that we've done that. One is we launched the first in the nation Healthy Opportunities pilot that is kind of paying for social need services, food, transportation, et cetera. It's been widely documented and now replicated all across the country. And it's a real bright spot, is being able to use Medicaid money to pay for food, because we know the person is not sick, they're starving, and that's what we need to cure. And we need to give doctors the tools and ability to do that, and built a whole infrastructure around making that possible. And lots of folks working hard on that. But then the other fundamental aspect in our program design has been to re-bring behavioral health back into the center of what we're doing. North Carolina carved behavioral health out of their Medicaid program years ago, and that was a huge mistake. By having these carved out programs, behavioral health became an afterthought, and we put it back at the center of what we're doing. And so I believe that behavioral health is in and of itself a social determinant of health. That, in the same way that this magic happens in our peer environments that we're talking about, people can't be well unless their behavioral health is good as well. Behavioral health is essential to health. And we see that in the data. Chronic disease costs increase when people have mental health challenges, whether it's managing diabetes or just medication adherence. Those things go awry when people are struggling with addiction or serious mental illness. And so we wanted to make sure that we could integrate those dollars back in to drive integration. Now we've paired that in with primary care coordination programs, trying to integrate care at the provider level, and a number of other efforts. But our next foray to add a third bucket is really intensifying this coordination for our children. So North Carolina has launched, haven't seen any other program like this in the country, a child and family specialty plan. Its focus is building on these blocks. So how do we bring social determinants into the puzzle? How do we bring behavioral health into the puzzle? And then to add on to that, how do we bring the whole child welfare aspect into the puzzle? Because these kids are getting wrapped around a lot of different systems beyond just healthcare, and all these systems are not working together. And so our challenge is that we're trying to rise to is, how do we use Medicaid dollars to drive coordinated care, not just within the health system, but within the entire child welfare system as it interacts with these aspects. So our child and family specialty plan aims to really coordinate across all these systems. To what I like to say is we have to wrap systems around people as opposed to stretching people around systems. And that's the benefit design that tries to get upstream in a very different way for these kids in particular.
Let me summarize. There was a lot there, and it was all gold. So three big, what I would say, cornerstone programs that the state of North Carolina has used to forward the whole person care mission. My words, not yours. The first is the Healthy Opportunities program around SDOH. And by the way, folks, if you want to check that out, I think it's impacthealth.org/healthy/opportunities/pilot. So find that program there if you haven't heard about it yet. And that's where you're addressing SDOH, moving Medicaid money to pay for food, etc. The second thing you did, and maybe not in order, chronological order, just the second thing you mentioned, was you re-centralized behavioral health as the middle or centerpiece of everything that you're doing. Primary care, coordination, and navigation of care, all important, but all ties in to BH. And the third is the coordination of care for children and this children and family specialty plan.
That's right.
Love it. That's fantastic stuff. Anything to add there? Did I miss anything? We're good.
Well, I think the only thing I would just add is, part of all of this, I think the challenge to policy thinkers is, look, you're spending a lot of money in your child welfare system, and you're spending a lot of money in your Medicaid system, and there's a lot of opportunity to braid those dollars together differently, and get a lot better outcomes for folks. And guess what? If we can do that for the kids now, we're going to save a whole lot of money and resources and have better outcomes for a very long time. And that's why it's getting upstream chronologically for the age as well.
Okay, let's not tell the governor, but we're going to temporarily give you a pay raise and take you out of your role.
Uh-oh.
Just for a few minutes.
Don't tell him.
No one's listening. No one's listening. But we're going to make you CEO of a Medicaid and Medicare health plan in another state. And you're not going because you're giving up on North Carolina. You're going because you want to change this country for the better, and North Carolina is going in the right direction. You go to a private health plan in another state. What would your CEO, what is like the first thing you're looking to implement at a Medicaid or care or plan that covers both? Like, what's one of the first things you're looking to implement?
This is going to sound a little silly, maybe because it's small, but I think it's where we have such good evidence base and such transformational opportunity. But I'm going to institute depression screening standards throughout all my, kind of value-based payment strategies to incentivize my primary care folks to do depression screening. We have and anxiety screening. We have such good data on how you can, with very easy, low cost coordinated care strategies, improve a number of measures by instituting that. And yet I feel like the market has struggled to really respond to that as a value, and it's such a low cost intervention. So I think step one, that's where I would start.
You're saying that's not being done regularly? Like,
no, it's still for as much as behavioral health continues to be a complete afterthought for the vast majority of systems.
Okay, and you were saying something else. I cut you off.
Oh no, yeah. So I don't think that is being done. And then the second thing that I would want to institute if I was in this magic CEO role in a state, well, there is no state greater than North Carolina, but whatever other state you've put me in, would be to get more involved on justice involved projects. I think that maybe this would be an evolving mission space, but when I think about economic opportunities for good returns and good value and just making people's lives different, I see a lot of inefficiencies in the criminal justice system with regard to health. And I think that the sea is changing in that space. We see the federal government moving to allow for more Medicaid services to be reimbursed in jails and prisons. There have historically been a blackout space there. 60% of people in jails have a substance use disorder. If structured right, there's a lot of opportunity to both improve lives and break cycles and drive down costs across a lot of different systems. And the justice involved population is one where there's a great deal of opportunity. I like to say that we believe that we don't have any community mental health centers in this country, but we do. They're the jails. And they have been out of sight and out of mind for so long, and there's just not the right financing model in place to help incentivize getting those realigned. That could be such a great return for society if we could figure that out.
Interesting. That's really interesting to think about. I know we're towards the top here of the hour. I want to switch gears a bit in closing. So a lot of people who have listened to this show know the origins of Bright Spots in Healthcare come from a story I read in a book called Switch by Chip and Dan Heath. I'm not going to get into the whole story, but in short, it was about a gentleman that went to Vietnam to solve malnutrition in the country and children in 1990. And he did it not by fixing poverty or finding more clean water or anything big like that, but he found it by identifying a bright spot and seeing how certain mothers were nourishing their kids differently. And that just colored how I thought about healthcare and why I do the show. And I've been doing it now for over 10 years. And I have since begun to just read more and more to inspire new ways of thinking, new perspectives, whether I disagree or agree. And so it strikes me I should ask you, someone that's worked at the federal level, now working directly for the governor of the great state of North Carolina, like what are one, two, maybe even three books that have greatly influenced your life, whether it was pre-professional, pre-adult, young adult, where you are now, that maybe you could share with us?
Okay, I'm going to give you 3 books. So, I'll give you 2 books on the inspiration category, and then I'll give you my 1 book read recently and why. So one, there's a book that I give to all of my newly promoted managers or executives, and that's I Moved Your Cheese. Everybody knows, who moved my cheese, but there was a, follow on written by a different author that, essentially tells the story. So here's the cliff notes that, the cheese started to move in the maze. And as opposed to it being about mice adapting, one mouse figured out that they could punch a hole in the wall. One mouse figured out they could make their own cheese, and one mouse figured out they could teleport. And the point of the story is that the maze isn't real. And for folks that work in government or any large bureaucracy, I think there can be no better lesson for people to learn than so many of the structures and the rules and the processes that we work. I mean, frankly, healthcare, for the rules that we have to navigate, that they are all created by us and they can all be changed. And we have got to take us. It's not about trying to get through the maze better and faster. It's about changing it fundamentally. And I think that is a super powerful book for new folks. Second book is Better by Atul Gawande. I'm sure other people have said that, as a person who was like an ops guy at my core and has worked in a number of fields as an ops guy, like taking a continuous improvement approach to healthcare and thinking about how to improve things is just a love language for me. And he is such a beautiful writer and big thinker. And then the book that I've read most recently that really touched me, that I think is important for the moment, is a true story by Jonathan Friedland called The Escape Artist. And it is the story of one of the few Jewish folks who escaped from Auschwitz. And it is an undertold story about this guy who got out and was able to warn the world about the horrors of what was happening in Auschwitz. And for a lot of reasons, both the story isn't told and the truth did not make its way out as loudly as it needed to be. And I think it's an important story for this moment more than ever about the power of facts, the power of truth, and the power of listening. And I would encourage everyone to check it out.
Wow, that could be the best answer to that question I've had yet. Well done. I Moved Your Cheese, Better, The Escape Artist. I already have it listed here. Beautiful. Well done. And just remind everyone where they could find more information about you, about the Children and Family Specialty Plan, and the Child Behavioral Health Dashboard, and everything else that you've talked about, and all the great bright spots in the state of North Carolina.
Yeah, I would check out our website, ncdhhs.gov. We've got some recent press releases that touch on a lot of these big things. You'll see information on our behavioral health investment roadmap, nearly $1 billion changing the game here in North Carolina. And please connect with me on all the socials and whatnot. And happy to partner with anyone and everyone that wants to make the world a better place.
Secretary Kody Kinsley, thank you very much for all of this. And thank you to everyone for listening. I know it's hard to fit on your calendar, and I don't take it for granted that you've tuned in. We hope that you use the bright spots shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. We produce this show for you. This is your Bright Spots in Healthcare podcast. Until next time, everyone, take care.